I am Dr. Shafali Walia, Associate Professor at Gurugram University, and I welcome you all to the session 1 of Physio Innovators. Physiotherapy India is in collaboration with Equidor Medtech LLP and has organized today's exclusive webinar to showcase the cutting-edge innovations in neurorehabilitation directly from the industry experts. I would like to invite as speaker for the day Dr. Srinivas Dorsala, who is the Director of Medical Product Innovation and Development at Equidor Medtech LLP. He would be speaking on the technologies for vertigo and balance testing and rehabilitation. I welcome you, sir.
Ma'am, thank you very much for this wonderful opportunity. Okay. So, emerging technologies in the diagnosis of vertigo and balance disorders is what I'll be speaking to you on. So, this is just a small tour of the setup that I have in Bangalore, the clinic. We call this a Center for Advanced Research in Vertigo and Balance Disorders. This is our consultation chamber. We have this kind of a consultation room where patient feels comfortable. Then this is the posturography testing. And this is the posturography rehabilitation. Okay. So the previous part was testing, and what you're seeing right now is the rehabilitation part with safety belt and all. This is the craniocorpography. There is a head-mounted camera. There is a head tracker. And what you're seeing right now is cranio-oculography. This is advanced video nystagmography, where you see the positional test presently being done. There is one more place simultaneously, just the ocular motor tests that are happening. This is another test with the cranio-oculography system. This is the manual chair. We can see the chair is rotating. At the same time, you can see the nystagmus in the video. And when the chair is rotating to the other side, you can see the oppositely directed nystagmus emerging. And when that stops, you can see the reversal of the nystagmus. Here in our clinic, we also do this orthostatic blood pressure protocol, where the person lies down and then stands up and we check blood pressure. What you're seeing right now is a functional head impulse test system. So this is like vision in motion. So when the head is being moved at a certain velocity, when the head actually crosses a certain velocity, exactly at that time, a particular optotype shows up on the screen. So when you see that optotype showing up on the screen, I'll just play that again. You can see the screen. A particular optotype shows up on the screen when the head is moving it for a small moment. So that is functional vision. This is video head impulse test being done. This is the vestibular ocular reflex test function. We are doing a WEMP testing. Okay. In this screen. So this is a brief overview of my clinic. So the things that I am doing in my clinic, brief overview. Okay. Now coming to some of the technologies that we at Equidor Medtech have built. This one is the force plate based posturography, the static posturography platform. This is completely made out of magnesium based alloy and aircraft grade sensors for measuring the force. So this is what we use for our posturography assessment. It's capable of 1000 samples per second. Okay, we can clip it to 100 if required, or depending on the studies that people are doing. But totally it is capable of 1000 samples per second from each force plate. So this is a simple protocol of a static posturography. This is usually called as the modified clinical test of sensory integration of balance. We call it escalating sensory denial. So we are seeing 4 protocols here. So, and when you see here, there is a nice stand, and the person has been for fall prevention. There is a belt, and the belt is fixed to the hooks. And there are 4 protocols that are happening here. In simple standing with eyes open on a firm surface, simple standing with eyes closed on a firm surface, then on the cushion with eyes open and on the cushion with eyes closed, a 4-step protocol. Like this, there are 8 different types of protocol that are available. Just for the sake of demonstration, I just picked up one protocol here being shown. Each of the recording is done for about 30 seconds in each of these protocol. Then you see a position plot where all the center of pressure shifted throughout. The center of pressure movement is what is shown. You can see naturally, as can be expected, that in this particular individual, that the ellipse area or the sway area is very small with the eyes open and on a stable surface. Diagonally opposite, in eyes closed and cushioned surface, you see that it's a huge sway, it's a huge ellipse area, and patient is really unstable. So these things are actually shown. Multiple measures are there. As an example, I'm just showing a few measures. That is a sway velocity and the maximum angle of sway that the person has happened. You can see there is a green area, yellow area, and a red area. That is to tell the comparison against the normative. So we can see it is entering into the yellow area here in the last protocol, that is the cushion surface, eyes closed. And we show the functional scores of the patient. How much is the vestibular score? How much is the somatosensory score in this particular individual? So this is one such test that we have, the force plate placed. We call this equipoise posturography system. Then the other technology that we have built is something called functional head impulse test. In the clinic tour also, you saw this test. This is a head-mounted system. You see this one. This is a head-mounted 3-axis high-speed gyroscope. There are 6 semicircular canals in each individual. Each of the 6 semicircular canals can be tested individually, and the test is the ability of the semicircular canals to help in foveation during head motion. Like when the head is moving, whether the individual is able to really move the eyes in the opposite direction. That tells the function of the semicircular canal. This is what is tested here. Now, in addition to testing that much, we also use this. I mean, there are different test protocols here. There is something called a tonic protocol and a phasic protocol. Because in the inner ear, there are 2 types of hair cells. There is a tonic cells and a phasic type of hair cells. So there is a protocol to test each one of them separately. Then in addition to that, this is a beautiful rehabilitation tool, because again, foveation in motion can be also rehabilitated. So we run optotypes of different sizes and different velocities the head is moved, and that is how you do. So a simple demonstration of how this particular test is done is shown here. So the examiner stands behind the patient and we just move the head side to side. This is for the horizontal semicircular canal. For the horizontal canals, we just move the head side to side. And when the head is moving at the fastest speed, exactly coinciding with the fastest velocity, is when this particular thing shows up. Okay. Exactly coinciding with the fastest velocity is when this particular optotype shows up, and that is how we test it. Okay. So that is the way this is done. Now coming to, yes. So then we can test for different canals, like for the anterior canals, posterior canals. The plane of stimulation is a little different. That's all. Other than that, everything else is the same. So this is about the functional head impulse test. This is one such device with high accuracy gyro sensors mounted on the head. Okay. The results are shown something like this. So this is a typical example of a patient in 1 year superior vestibular nerve when it is gone. You can see how these results are. There are 6 semicircular canals. So there are 6 limbs to this head chart. And there are green zones, yellow zones, and red zones. In this particular individual who had a superior vestibular neuritis, you see that the 2 canals functional, which is supplied by a particular nerve, the superior vestibular nerve, the function is reduced. All other canals, the function is in the green zone, like this. Then there's another person in whom we can see all the canals on one side is gone. That is, that one inner ear is completely damaged, complete vestibular neuritis. One inner ear's vestibular part is completely damaged, or the nerve is completely damaged. Okay, like this. The next key innovation that we have, or this is the actual cornerstone of our technology, that is the EquiCOG. Previously, we used to call these things as video nystagmography systems or video oculography systems. We have advanced the technology to such an extent that this needed a separate name. We call this as a cranio-oculography system. So this is advanced version of video nystagmography. What we do here is there are a lot of tests that we do. One of them is a test for nystagmus. Okay. A test for nystagmus is what we do. So you can see things here. She's wearing, and what the eyes of this individual are being looked into. When you see, she is in complete darkness because she is wearing a goggle and she can't see anything. So because she is in a complete darkness, it is equivalent to removal of fixation. So when fixation is removed, any underlying eye oscillatory abnormality, which is suppressed when the person is seeing, shows up. So this is what we are doing. We ask her to look straight, look right, look left, all of these things. There are multiple different protocols that we can run. In this, we can ask the person to close the eyes, then open the eyes. These kind of things we do. Look up, look down, all of these things. See, we ask them to close the eyes tight and then remove, open, see any kind of problem. And the same thing is being in real time. You can see the plus mark in the center of the eye, in the center of the pupil. That is the eye tracking happening in real time. And that real time real-time rendering of the plot is also there. So this is the cranio-oculography system. So just to give you some examples of what all we can do with this cranio-oculography system, you can simply do, you can see this person. When you look at the eyes, you can see that the eyes are simply beating towards the left. We do something called a head shaking test to enhance any asymmetry between the right and left ear. And when we do that, the previous nystagmus becomes even more enhanced. We can graphically measure these things. You can also see that the head of the patient is slowly deviating to one side. I'll just demonstrate that again. You can see here, after the head shaking is stopped, the head of the patient is slowly deviating to one side. So the best part of this technology is that in addition to capturing the eye movement, we actually capture the head also, what exactly is happening to the person's head at that time. This is so key, especially in some positional tests and all of those things. So this is one example of a rare variety of positional vertigo, benign paroxysmal positional vertigo. A lot of us deal with these things where the person, when they turn their head, when they get up, when they lie down, they start getting nystagmus and they start getting vertigo. So this is one such example in a person. This is our method. We make the patient bow the head down, and then we take the person into what is called as a Dick-Salpike test. So from the head bowing down, we take the person to that position. We can see in real time the camera orientation also changes to give a best view, and the eyes are not really showing much of any nystagmus. But the moment we lift the head up a bit, okay, the moment we lift the head up a bit, you can see that. So again, I go down to enhance that. Then I lift the head up. You can see this nystagmus. The eye starts showing this kind of a jerky pattern. So this one is called as a short arm of the posterior canal benign paroxysmal positional vertigo, a different variety. The beauty of this technology is you can actually see what is happening to the eyes in which head position. So that gives a much bigger insight to the doctors as to what exactly is going on. You can review the video and simultaneously there is a graph. Okay, there is one more test we can do. This is a bow and yaw maneuver. Okay, so all of these things in naked eye examination, it's not possible because just see what happens in a bow and yaw maneuver. In a bow and yaw maneuver is a treatment for short arm. You actually put the patient upside down, in the sense the head goes fully down. You can see this. With the naked eye, to examine a nystagmus in this head position is impossible. Okay, whereas with a goggle mounted which moves with the patient, all these things are possible. And you see when we do this bow and yaw, we make the head turn. Now you can see the eyes is showing this, what is called as a downbeat nystagmus, the oscillation, which tells that the crystals in the inner ear are moving in the expected direction, in the correct direction, and we are getting a cure. So this is what is called the bow and yaw maneuver. There is a new finding that the other beauty of this particular system called cranio-oculography is that it has a pupillometry protocol. Pupillometry is where the size of the center black part is in real time actually monitored and measured. Here you can see a person with vestibular migraine. The pupil is becoming small and big, small and big. So it is like a pulsation of the pupil. It is going down and small. So this nowadays is being recognized. Previously, it used to be considered as physiological because it used to be so commonly seen, but now it is being recognized that it is actually part of a migraine. Okay, so a lot of people with migraine start showing this pattern. You can see the center of the pupil. When you see the pupil, it is showing the dancing pattern or the oscillating pattern. The name of this is hippus. So because of the pupillometry, this is just one protocol that is that I am showing. There are several protocols. There is something called as a consensual light reflex. Okay, direct light reflex, accommodation response, Okay, there is swinging arm, that is the afferent pupillary response or afferent pupillary defect kind of protocol. There is something called a dark reflex, which tests this sympathetic response. All of these protocols are available. Exact velocity with which the pupil constricts and dilates. Okay, the time taken for constriction, time taken for dilatation, all of these physiological studies are possible with this. It can be used as a pain scoring system also. So that is one method. So there are so many things, like a typical use case for this is like to record. I've shown enough positional nystagmus. I'll just give one more example of a positional vertigo. You see when the patient goes down to this particular position, okay, that is the Dick-Salpike position. You see the eyes are showing the oscillation pattern called the upbeat torsional nystagmus, which is so typical of left posterior canal, benign paroxysmal positional vertigo. Not just the upbeat that is seen here. When the person comes up, the reversal, which tells that the crystals are now moving in the opposite direction, also is established. So there is one direction of crystal movement when the head goes down. There is just the opposite direction of crystal movement, that is reversal, when the patient comes up. So which is so beautifully demonstrated. See with the head comes up and you can see that the eye starts beating down now. Okay. So this is the beauty of this kind of recording. So this is one such system. I showed in the introductory video a rotary chair. If you see a rotary chair, if you put the person and put the head in different positions and rotate the person in a rotary chair, different kinds of nystagmus patterns, which are all physiological, can be studied here. You can see there is a torsional kind of nystagmus that is there. Okay. Then there is a horizontal nystagmus when the person is rotating. All this is physiological. Every normal person should get this nystagmus. So this can be a beautiful tool for studying physiological. When the person turns the head to one side, then you get this kind of a vertical beating nystagmus. All of these things, none of them are pathological. All of these things are physiological. Okay, so it can be. Of course, in pathology, the way in which this presents changes. So this is one such nystagmus. So multiple examples we have of different patients. This is another pupillometry where when the light starts coming, you can see the pupils suddenly start. You can see the pupils become small. When the light comes to one side, on the right side or left side, okay, right side, both eyes become small. So this is both direct and consensual light reflex we are testing. So this is the pupillometry protocol. So in addition to studying positional and all of these things, we do have a pupillometry protocol. Then there is this a beautiful tech. This is called craniocorpography. In craniocorpography, you see this orange and blue balls. This orange and blue ball are head trackers. This is kept, and this camera is ceiling mounted. So through the ceiling mounted camera, when the person wears the head tracker and starts making movements, whether walking, whether tandem walking with eyes open, tandem walking with eyes closed, whatever the person does, the trace path of that particular movement is done. So here you are seeing an example of an Unterberger test where the person with eyes closed takes steps in place. Okay. Now, when a patient is made to do this kind of a work, so though the instruction is to stay in place and not turn, people with vestibular disorders tend to turn to right or to left and all of these things. In spite of the instruction to step in place, what you are seeing is he's proceeding forward. He's just moving ahead. So these kind of problems are known. And we have multiple protocols here, like a tandem walking protocol, a Romberg's protocol can be measured and all. And all of these things are shown in real-time graphical display. You see on this right side that there is a graph that shows the exact walk path of this particular individual. Okay. And it shows in this thing. The accuracy is like in 1 centimeter level, the accuracy we get. There's a beautiful new way in which we have figured out how to there's a beautiful way in which we are now grading the ataxia in using a score called tortuosity score. Tortuosity score, especially in walking. So if the tortuosity score is low, that is the lowest possible score is 1, the highest possible score is infinity. But most of the people with sensory ataxias and all of these things, they show, when you make them a tandem walk, they show a tortuosity above 2. Whereas a normal individual, most of the people will show tortuosity score between 1 to 1.1. So this is how we measure, we give a score to the ataxia, the kind of walking. Okay, whether the walk path has been straight or it has been too wavy or whatever it is, we can come to know in different conditions. We do have protocols where we make them turn 360 degree to the right with their eyes closed for 1 round, 2 round, 3 rounds like that. so that we can actually measure what is the internal representation of their movement. Sometimes they overshoot in one direction or they undershoot in one direction. These kind of measures are all possible with this craniocortical. So these are some of the primary tools. There are so many other tools in the pipeline that is being developed and is going on happening. But I thought I will show these many things with some clinical examples, and this is my presentation. Okay. And then you saw the last one is the rotary chair. You saw this in the beginning only, the rotary chair in my introductory video, how we use this. We use this both for measuring, that is as a test, and we also use the rotary chair for rehabilitation purpose. In rehabilitation, we use them to desensitize people. We also use them to make them better focus their vision when they are moving. So we give them books to read while one of the assistant is making the person to rotate. Okay, one of us is rotating the person, and at that time the patient is given a book, these kind of things, and the results are really amazing. Okay, really amazing. Okay, so thank you all. Thank you so much.